Hello, everybody. On behalf of the Chicago Asthma Consortium, I would like to welcome you to today's Lunch and Learn called Getting Smart About Asthma. And this is going to be a review of SMART therapy, the new guidelines that went into effect back in December of 2022. We're really excited to have this forum today, and I'm really excited about the speaker who we have. So we'll go through a couple of just welcoming sort of like housekeeping slides. And then after that, we'll move straight into the presentation. I am today's moderator. As you can see, I'm the president of the board of the Chicago Asthma Consortium. I'm also the executive director of Mobile Care Chicago, which is a not-for-profit organization that uses mobile clinics to travel around the city of Chicago and provide medical care for people who have asthma and allergies. So our schedule for today, I'm just going to go through a couple very brief slides to give an overview of the Chicago Asthma Consortium and what we do. I'll also introduce our speaker, and then I'll pass it over to Dr. Petrykiw to then go into her presentation, and then we'll do a question and answer session afterward. You won't need to have your video on, and you won't need your audio either. We'll handle the question and answer through the chat function, which I'll talk about in just a little bit. So as I said, video and audio you won't necessarily need. And if you have technical difficulties, you can contact Kay in the chat, or it's CAC headquarters. We also welcome everyone to introduce yourself in the chat. So please feel free to say hello. And if you're interested in what someone else is doing, feel free to have side conversations in the chat as we kind of go along. If you have questions for our presenter as we sort of move through the presentation, you can put those in the chat as well, and I'll make sure to aggregate all of those and then bring them back at the end, and we'll make sure that everything is addressed in the Q&A. At the end of the presentation, we'll also have a brief evaluation. This helps us to provide material and content that is useful to you, and also gives us really important feedback on just things we can do differently or better. So please, we welcome your feedback, and I hope that you'll share your thoughts. A little bit about the Chicago Asthma Consortium. CAC has been around for almost 30 years now, and we're an organization that seeks to improve the quality of life for people who have asthma. We do that primarily through advocacy, education, and collaboration. And really, the collaboration component of that becomes the most important. There are a lot of people who work on asthma issues in the city of Chicago. There's also quite a lot of research that's happening, direct service, and then there's also quite a lot that schools do in Chicago to help with asthma. So our goal is really to bring together all of those stakeholders to make sure that we all understand the most recent guidelines for asthma, different therapies and different outreach approaches that are effective. And so you'll see that there's a number of public health professionals, business leaders, government agencies, community-based organizations, and just individuals who are passionate about asthma either because they have it or they are a caregiver of someone who has asthma. So if you'd like to join us, you can learn more about us at our website, chicagoasthma.org. And different ways that you can help. Chicago Asthma Consortium is a volunteer organization. We are structured through committees, and all of those different committees have separate goals that they work on to try to further quality of life for people who have asthma. So if you'd like to volunteer with one of our committees, we have a community advisory board, a community engagement group, we have a fundraising group, a membership group, and then we also have a professional development group, which is the committee that puts on forums like this one today. If you're interested in joining the board, we are also accepting applications, and you can learn more about that by contacting us at the info address here at chicagoasthma.org, or you can just send me something in the chat, and I'll send you my email address. And with that, I'm really excited to introduce today's presenter, Dr. Christina Petrykiw, who completed her Doctor of Pharmacy at the University of Illinois Chicago College of Pharmacy. She completed a pharmacy practice residency at Michael Reese and University of Illinois Hospitals and Specialty Residency in Drug Information at the University of Illinois Chicago College of Pharmacy and Medical Center. Currently,
Christina.
Dr. Christina, thank you. Sorry for butchering your name, is a clinical pharmacist and instructor at the University of Illinois Chicago College of Pharmacy, where she conducts drug utilization review for Medicaid and provides academic detailing with Illinois Advance, a free state-mandated program. Her past work experience includes being the inaugural pharmacy practice faculty member at Midwestern University College of Pharmacy, director of drug intelligence and medication management at Premier, and then a drug information specialist at Rush Medical Center, as well as a clinical pharmacist and diabetes educator at Chicago Osteopathic Medical Center. So, Dr. Christina, I'll pass it over to you, and thank you so much for being here today.
Thank you for having me. I'm excited to meet with everyone and kind of help us all get smart about asthma. Some of my objectives today are to kind of look at where we are with asthma and asthma legislation in Illinois, as well as look at what the medications and their role are in asthma management, and more particularly getting involved in the components of SMART therapy, guideline recommendations for SMART, and then some comparison to other asthma reliever therapies with SMART. And I want to briefly also touch on the use of SMART in exercise-induced bronchospasm. We are all working with asthma patients or have family members with asthma here in Illinois, but it's always enlightening to kind of take a bigger picture and see what the prevalence is. In adults, we're about at 8.7% in Illinois, which is actually higher than a national average prevalence of about 8%. In children, it's about 5.3% prevalence in Illinois. We do have emergency department visits and hospitalizations due to asthma in particular, and we have had deaths in Illinois due to asthma. And when we take a look at the asthma deaths, it's about 3.5% of all asthma-related deaths in the US have occurred in Illinois. We don't have Illinois data, but nationwide, we do know that about 40% of children and adults have had one or more asthma attacks in the last 12 months. And working or having asthma, we are very aware of the missed school and work days that occur either directly as the patient or as the caregiver. We do tend to have within the prevalence in Illinois more females than males experiencing asthma, and our non-Hispanic Black population has the highest prevalence in Illinois, as well as patients who have a lower income of less than $155,000 per year. In terms of mortality, it kind of tracks the more prevalent asthma groups have a higher incidence of mortality, and our older population, our adults and our patients that are 65 and older or elderly, are to events of mortality. Because some of you are involved in school-based care of patients with asthma, I just wanted to touch on asthma legislation so that everyone would be aware that we do have some mandates for medication and treatment in Illinois. The first legislation in 2010 allowed students to self-carry and self-administer asthma medications as long as there was a written authorization for the parent or guardian and a prescription label that clearly defined dosing and utilization directions. The second legislation required staff that are working with students with asthma in all schools, public and private, to undergo emergency response training every 2 years. And subsequent legislation facilitated the ability for a school to stock asthma asthma rescue or reliever medications in the school. They do not specify exactly the medication, but some tools and guidelines for schools currently only talk about albuterol, and so it is something to take a look at if you are working within a school to see what your protocol specifies. This legislation authorized additional administration by school staff if there is an emergency or an exacerbation. And it solidified, again, the self-administration by the student, and then also allowed the staff to administer the inhaler depending on what the action plan specified. Our goals in asthma management are to get good control of symptoms and try to maintain normal activity levels for the person with asthma. We also strive to decrease morbidity and mortality in emergency room visits. And ultimately, we don't want asthma to turn into a persistent airflow obstruction or limitation. And so treating early is something that we try to do. Additionally, we're always trying to decrease side effects and are trying to work with the patient to ensure that we are aware of what their goals and treatment preferences may be. Working with asthma, we're all familiar with the pathology, but I just wanted to remind everyone that we're always working with a dual mechanism within asthma. We do have the bronchoconstriction, a component that impacts the muscles and narrows the airway, and we also have reactions that are occurring within the asthma, and it is an inflammatory response that increases the production of mucus, which then kind of sits in the airway, and then irritants might get trapped in that mucus, and then that furthers a lumen reaction and the walls of the bronchioles, which causes swelling. And so our clear airway becomes fully, not fully, but significantly obstructed, decreasing the ability to breathe. Our medications are trying to target these dual mechanisms. Our bronchodilators, the short-acting and long-acting beta agonists, the xanthines, and the theophylline, and our long-acting muscarinic agents are trying to target the bronchoconstriction. Our corticosteroids are impacting the inflammatory response in the mucus, and then our cells in the lumen lining are impacted by leukotriene modifiers, so agents like montelukast, our mast cell stabilizers, and the newer biologics. In terms of guidelines, we've had two sets of guidelines in the US. We've had the National Institutes of Health and the National Asthma Education Program update their guidelines on select issues in 2020. And if you're familiar with asthma management, you know about stepwise therapy. So we can go from intermittent asthma to persistent asthma. And as the asthma severity increases, our management increases, and we follow steps. And so the National Asthma Education Program follows 6 steps. And has defined age groups as noted, 2 different age groups for pediatrics, and adolescents 12 and older are grouped with adults. GINA, or the Global Initiative for Asthma, is a World Health Organization guideline that is updated annually, and it differs because it has 5 steps rather than 6 with the National Education Program, and the definition of the pediatric age group differs slightly, but the adolescent and adult group are 12 and older. When we're looking at asthma management, we have asthma reliever therapy or rescue medications that are used as needed, and we have controller medications. In terms of reliever medications, what we've had in use for the longest time are short-acting beta agonists, or SABA, monotherapy inhalers, and the National Education Program uses this as the preferred reliever for steps 1, 2, 5, and 6. And GINA recommends an inhaled corticosteroid, or ICS, formoterol as the preferred reliever therapy in adolescents, adults, and asthma of all severities. But when we take a look at the newest guidelines, we also have introduction of new terminology for the relievers. We have the short-acting beta agonists, and we have the anti-inflammatory relievers, or AIR. Traditionally, we would achieve this with a SABA and an inhaled corticosteroid as a separate inhaler. We then had the combination inhalers, ICS with formoterol, being utilized as part of SMART therapy as a reliever. And within the last 2 years, we've had a combination inhaler, albuterol with budesonide, that has been introduced, otherwise known as Air Supra, that can be used as a reliever as well. This table just has our the medications that we kind of touched on a minute ago in terms of rescue therapy, and compares them and provides the brand names. So we do have the short-acting beta agonist combination therapies with steroid inhalers, with steroids in them, and then short-acting anticholinergics that may be used in asthma. But primarily, we see the top two classes utilized. The effects of beta agonists that we're relying on are the bronchodilation. The bronchodilation is very effective with the beta agonist. It doesn't matter what the mechanism for constriction was, they will work to bronchodilate, but they don't impact the late asthmatic response to allergens and or bronchial hyperresponsiveness that can occur later. And this helps us understand that there really is no anti-inflammatory activity with the beta agonists. Within the beta agonist class, they will differ based on their duration of action and some of the cardiac toxicity between agents. I wanted to touch on the comparison in terms of the kind of we call it the kinetics, how something starts to work and how long it works, because it becomes important in our understanding of when certain therapies may be used. Our short-acting beta agonist albuterol starts to work within 1 to 2 minutes and usually lasts about 4 to 8 hours. With exercise-induced bronchospasm, it can last up to 4 hours. Our long-acting agents include, technically termed long-acting, are formoterol and salmeterol. Formoterol, which is what is being used in SMART therapy, starts to work as the same as albuterol, but it has a longer duration of action. So formoterol actually shares characteristics both with albuterol in terms of onset and with longer-acting agents in the class in terms of duration. The reason we have concerns with albuterol therapy is that we end up having tolerance develop or tachyphylaxis within 2 weeks of regular use. And this results in increased hyperresponsiveness, a decrease to the response of bronchodilation that we're expecting with use of the agent. And so that leads to increased use. And because we're only addressing one aspect of the pathology of asthma, we're getting increased inflammation because nothing's addressing that. So when we have excessive use and a poor response, we end up having poor control and increased exacerbations. We can actually take a look at patients who are using the SABA monotherapy inhaler and kind of predict if they're going to have or have increased exacerbations and or mortality risk. And so more than 3 SABA canisters being used, not just because I need 3 filled because I'm living in different homes or I need one at work at school, but actually utilizing more than 3 inhalers in a year and or increased mortality if I've dispensed 12 or more canisters in a year. And so overuse of albuterol ends up causing a need for emergency room visits because we need additional help to manage our breathing. And we can also have adverse side effects such as tremor and tachycardia when we first start therapy, and then if we're overusing the therapy. Sorry, I was having problems expanding the slides, and so I I apologize for zooming through several of them. When we look at the guidelines, steps 3 and 4 are where there is a preference for the use of the combination smart therapy inhaler controller and reliever. And so we can see by step 3, we are already starting to use a combination product. And what we're doing with smart therapy is then utilizing the combination inhaler PRN in addition to what we may normally do at step 3. And so your patients with moderate to severe asthma may be using the inhaler for maintenance once a day in step 3 or twice daily in step 4, and they would then additionally use the inhaler PRN. There is a number of recommended inhalation in pediatrics of 8 per day for use of the combination inhaler, so combined maintenance as well as reliever therapy. And part of that is because we don't want excessive use of the beta agonist. We know that the medication the use of the maintenance combination works, and it's been compared to high dose corticosteroids in children. And we see that with utilization of smart therapy, in the bar graph, you can see the green, we have fewer exacerbations that require medical intervention. And the medical intervention within the study was looking at, I have to give oral steroids to help improve the asthma, or I have hospitalization or ER visits, or I have to increase the dose of the steroid. With smart therapy, besides fewer exacerbations, we also had patients have fewer awakenings and a lower total steroid dose needed. When we're talking about steroids in the pediatric population, one of the concerns is always impact on growth. And so it is important to realize that we can have systemic effects when we're using high doses of inhaled corticosteroids. We might see some growth retardation as well with lower to medium doses, but that tends to be transient. You have some effect on growth velocity within the first 2 years, and then that normalizes. And so normally an impact of 1 to 2 centimeters. We are seeing that as patients that are pediatric go through their growth spurt, that kind of ameliorates, but there may be cases of it persisting into adulthood. And so SMART has been compared to high-dose corticosteroids with PRN SABA to understand whether there's an impact on growth. And we see that children utilizing SMART therapy had a growth of 1 centimeter or more compared to children who were on the higher dose corticosteroids. And so there is less of an impact on growth when SMART therapy is used. In adults, the same concept within the guidelines. Both guidelines concur that SMART therapy should be utilized when the patients get to the moderate to severe aspect. With adults, you can, according to the GINA guidelines, you can use the ICS combination with formoterol starting with step 1 in patients. So GINA would promote the exclusive use and substitution of SABA with an ICS formoterol inhaler. In adults, we're using the higher dose inhaler with this 160 milligrams of the budesonide, and we're also experiencing a max inhalation, but in adults, it's higher than pediatrics. You can have up to 12 inhalations per day. In the adult patient population, we've had, or adolescent and adult population, 12 and older, we've had multiple trials conducted looking at SMART therapy and comparing it either to PRN SABA monotherapy or combination therapies. And we do see that at least 50% of patients have had fewer severe exacerbations compared to other therapies when they're using SMART. And SMART has also decreased emergency room visits and hospitalizations by at least 65% compared to monotherapy with SABA, and almost 40% decrease compared to using 2 inhalers and ICS and a PRN SABA. So when we take a look at GINA and SMART and compare them in terms of SMART therapy, we see a slight difference in terminology, but we're basically looking, SMART is single inhale maintenance and inhaler therapy, where MART is maintenance and reliever therapy. So you might see those interchangeably in the literature and guidelines. Both do recommended for steps 3 and 4, and then additionally GINA promotes against SABA monotherapy because there is more efficacy and safety with an ICS formoterol combination. Our SMART therapy candidates would then be anyone 4 years of age and older who has moderate to severe persistent asthma. Patients who have had a history of exacerbations may benefit more from SMART therapy. And if a patient is uncontrolled and they're using a long-acting beta agonist combination with a steroid and PR and SABA, the recommendation is to consider SMART therapy before increasing doses of steroids. A patient who is stabilized already on therapy should not be switched to SMART. And also the ICS formoterol would not be an appropriate rescue medication for a patient who's using a different long-acting beta agonist. Our benefits, as we have seen from our slight discussion of trials, is that we do get quick relief of symptoms. It's easy to use because I'm using only one inhaler for 2 purposes. We do know that we have a decrease of exacerbations and a lower total dose of steroid use, and the therapy has been well tolerated. Just briefly related to exercise-induced asthma, because this in particular in children, but also our adult athletes becomes an issue. Exercise-induced bronchoconstriction occurs about 5 to 15 minutes after physical activity has started. And so we try to provide a therapy preventatively before exercise has started. And so the treatment options are 1 dose of monotherapy SABA, 2 puffs 10 to 15 minutes before exercise. Additionally, if there's frequent need, then an inhaled corticosteroid may be added. But for exercise-induced asthma or bronchoconstriction, it may take some time before you see the maximal effect of the steroid. And then alternatively, you can have daily leukotriene receptor antagonists such as montelukast used, and mast cell stabilizers have also been used. A patient who is using SMART can use the inhaler 1 puff 5 to 20 minutes before exercise. We have seen some trials that have been done in the adolescent adult population, and it compared to the SMART therapy to budesonide monotherapy. And because it was a European study, it was done in Sweden, their rescue inhaler was actually terbutaline. And so those were the comparison. And we saw that there was up to almost a 30% decrease in exercise-induced bronchospasm with using the combination inhaler. As we start to utilize SMART therapy, we need to make sure that our asthma action plans incorporate these inhalers. And so there are, I believe, based on last month's Lunch and Learn, that this is also provided as a resource on the consortium's website. But do make sure that your asthma action plans reflect the current therapies the patient might be using. And I know there's always a question about insurance coverage if using SMART therapy. I provided within the table more detail on the Illinois Medicaid coverage, but in general, when using SMART, please be aware that you might need to have prior authorization if the Symbicort or in some insurers are also utilizing Dulera, which has a different steroid, but is the other formoterol containing inhaler in the United States. If something is not on formulary or not on the preferred drug list, or their quantity only allows 1 inhaler, you will need to do a prior authorization to explain why the patient needs something beyond what the regular coverage is. And so if you're not sure what or don't have time to check on the coverage, do request prior auth so that the approvals are in place when they go to pick up the medication. If the therapy gets denied, at the point of sale when the patient presents. Oftentimes we find patients have a hard time going back or letting the provider know, and so we can go for a longer time period not having our medications. But in terms of Medicaid, I did want to provide that there is one preferred drug list now for the managed care and fee-for-service Medicaid coverage, and so the Symbicort as well as Dulera are covered, but in particular for the Symbicort, the quantity limits. For fee-for-service, there are no limits, and all of the managed care plans, except Aetna, allow 3 inhalers for 30 days. Aetna is currently allowing 1 per 20 days, so you kind of, within a 30-day period, may be able to get 2. So our take-home points, SMART entails use of a single combination inhaled corticosteroid beta agonist inhaler, both for control and relief of asthma symptoms. The guidelines support use at steps 3 and 4 of asthma management. It is effective in decreasing exacerbations as well as emergency room visits and hospitalizations, and does demonstrate less bronchohyperresponsiveness, a late-stage response, and less growth retardation compared to other therapies. And it can also be utilized in exercise-induced asthma or bronchoconstriction. I did provide some links to resources that might be helpful. Healthy People to 2030 is our goalpost for the nation, and it does trickle down to the state level and county levels. So there are respiratory disease asthma markers where we're trying to decrease exacerbations and hospitalizations and emergency room visits. We do have an asthma state plan in Illinois that provides some guidance on what initiatives may be occurring at the state level. Just recently, a few weeks ago, JAMA published a systemic review of inhaled reliever therapies for asthma. It does support use of corticosteroid for relief. And then there are 2 other links that might be helpful in terms of how to use the different inhalers, and then also some mobile apps that may be helpful in patient care. The rest of the slides have references, and I do have a plug for Illinois Advance if you want further, more detailed addressing of either the relievers or additional guideline information. SMART was not the only guideline update that has occurred, as well as any information about the I'm blanking on the devices that we can use with asthma or other chronic diseases. Please definitely, I encourage you to sign up for a visit with Illinois Advance as we collaborate with you to improve asthma care in the state. I'm going to stop sharing.
Thank you.
I don't know if there have been questions.
There have been some questions, and I also wrote down a couple. Yeah, one of the questions is this information shared with school nurses? There may be some confusion if a child brings Symbicort opposed to albuterol to school.
I don't know, and it's actually one of the things as I looked at the legislation doesn't specify the reliever therapy, but when I looked at some of the materials that were posted either by various entities within Illinois that provide tools and how to set up the school supply aspect and what an asthma care plan looks like, they were still all just referring to the SABA inhalers. And so I don't know how legislation trickles down to the school level. Legislation usually just says do something. It usually does not provide clarity on implementation. And so it would probably be good to reach out perhaps to the Board of Education and what recommendations they're putting out to the schools.
Okay, thank you. And Christina, we did also get a question about the using smart therapy or using a combination inhaler for pre-treating for exercise-induced asthma, which I know you went over later in your presentation. But But I guess if I could ask a follow-up question about that, like how would you recommend talking with families about that? Because I know, there's a lot of sort of I don't know, there's a lot of knowledge that people have about the way that their asthma was treated as a kid. And then, if this is a particular way that their child's asthma is being approached and it looks different from what they're used to, I wonder if you could just talk a little bit into about like how to approach those conversations.
So I think one of the things to keep in mind is to perhaps address the fact that it's going to depend on the child. Their guidelines and our management changes as we learn new knowledge. And so if a child is someone who's very prone to exacerbations, it makes it a little bit perhaps easier to have the discussion of we see that if we address both inflammation and bronchoconstriction at the same time, that you'll have fewer exacerbations. Someone who has been on SABA only or the albuterol inhaler only for exacerbations is going to be may be very resistant to changing. Implementing smart therapy is easiest when you have a new patient. When it's a patient who hasn't, you have to return to the discussion. And initially in the guidelines, I don't see it noted as much now, but smart therapy started being talked about around 2018. And then when they talked about the fact that you'd have the combination inhaler, they also noted that you'd still have a SABA inhaler. And so the recommendation initially was use the combination inhaler first. You can repeat within 5 to 10 minutes. And then if you're not getting relief, use your SABA inhaler. So kind of that crutch was there, especially for patients who are switching therapies. But I guess if I was a parent who had asthma and it was being treated differently, I would first address the fact that as we learn more information and we have and we see the data, we change how we manage the therapy, and potentially would even encourage the adult patient to convert to a combination therapy so that they can have fewer or less severe exacerbations. I don't know if that completely helps. There's probably more avenues, but it kind of depends on the patients.
Uh-huh. Yeah, I appreciate that. And we've got a couple more. So yeah, Mark asks a question about is the ARG variant of the B2 site ever come into discussion with failure of therapy for rescue with SMART?
I don't know. I can research that and send that back to the consortium, and then they can send it out to the attendees because I think you'll have their contact info.
Yeah, and Pam asks, it seems like you continue to lean towards the NIH guidelines. Is that correct?
Okay, to be honest, as a practitioner, I lean toward the GINA only because I know on an annual basis I get updated information. But in some quarters, we tend to, within the US, we tend to like to just follow the US guidelines, and we'll say, oh, international guidelines don't apply. I've seen that pushback. And so I was thrilled that the NIH 2020 guideline concurred with the GINA and updated one aspect in terms of incorporating SMART in stage 3. Unfortunately, it's been 4 years and there hasn't been any additional update. And in that time period, we've had additional new products come on the market. And so in practice, I think we tend to lean more toward GINA, but I do understand that there's sometimes a preference to use just US-based guidelines.
Yeah. And I know we're over time, and thank you so much to those who were able to stick around for questions. I did have a question just about how SMART could potentially complicate ER discharge, and if you have some insight on that. I mean, my understanding is that for especially if someone like has a like either does not have a formal diagnosis of asthma, but they have a pattern of ER use for bronchoconstriction or for shortness of breath, or if someone does have an asthma diagnosis, but like the understanding in the ER would not necessarily be really nuanced about like the type of asthma, that like how how would they potentially approach discharge? Like and would they still sort of like defer to albuterol as the sort of like um general script that you would give to someone who is discharging? Or yeah, I wonder if you've had any conversations with ER docs about how they're approaching that.
I haven't had any conversations, but I do know that there was an initiative, and I don't know if it's just Chicagoland or if it was Illinois based, where the ERs were managing asthma patients differently than before and ensuring that kind of the maintenance component got incorporated. I'm not sure if it was a SMART initiative, where we're trying to make sure the patients get onto SMART therapy within the guidelines. It does note that if I'm presenting with an exacerbation, and let's say it's my first, maybe not when it's my first exacerbation, but if I present with an exacerbation and I previously was intermittent or mild asthma, just presenting to the ER with an exacerbation qualifies me as a moderate to severe asthma patient. And so SMART therapy and or incorporating an ICS with a longer acting beta agonist is the step that should be taken when you're in, if you've presented with an exacerbation. I think that has to be nuanced with, what were the circumstances? Did you run out of meds? There's some circumstances that need to be taken into account. But I do not know if there are official protocols now in the ERs with the change in availability of products that have corticosteroids. In addition, it might be a good lunch and learn with the ER group.
Oh, great idea. And yeah, for those of you who haven't yet, we have a survey that Rochelle put into the chat, our executive director here at CAC, and we'd love to hear from you if that's something you're interested in. Kumar asks one last question, and I think we'll have to end after this, but they asked, most studies that evaluated SMART therapy look at Symbicort. Do you have any concerns for extrapolating this data to Dulera, if that is what the patient's insurance preferentially covers?
Quite honestly, initially when I saw, there were two, beclomethasone and budesonide, that were studied in mostly European studies for SMART, but Symbicort was the only medication that has had a lot of studies. There is at least one study ongoing with Dulera, but I have seen insurers have both on formulary and allow either for SMART therapy. I think the key component ends up being the formoterol, being the beta agonist within the product. My first reaction was like, well, I don't have definitive studies that show efficacy, but I started to understand, and even with the newest, the 24 guideline, they now say ICS formoterol versus specifically saying that it has to be a budesonide formoterol. And so I think I've calmed down a little bit. I do know there's at least one study, and if I can find that, I can share that. But the key component is the formoterol because it has fast enough acting and has enough duration of activity to facilitating managing the bronchoconstrictive aspect of asthma, and the steroid will then address the inflammatory component.
Thank you very much. And I think with that, we'll have to end the questions for today. Thank you, everybody, for submitting your questions. Thank you so much, Christina, for being here with us today. And like I said, if you could take the survey, that would be really helpful for us, those of you who are still in the chat. And again, yeah, if you would like more information, you can go to our website, chicagoasthma.org/events, and we'll be posting all of our future Lunch and Learns there. So thanks very much, everybody, and have a great day.
Thank you.